So thank you very much for inviting me in this forum. So actually,
It is our pleasure.
thank you
The
very,
Indonesian Pinnacle Spine Club and the Indonesian Spine Society is a very, very active society in endoscopic spine surgery. It is our honor and privilege to invite you, Dr. Lufti, Dr. Ikap, and Dr. Harpantya, and Dr. Asrafi. All of you are welcome, sir. Please start your presentation, sir.
yes, thank you very much. So my topic today is the factors associated that influence successful or failure in endoscopic spine procedures. As all we all know that the endoscopic spine procedures is widely used in the world right now because since there is advantages and disadvantages of these procedures that we can use these procedures better than before. All right then. So as we know that Mixter and Barr, 1934, reported first microdiscectomy, and in Jakarta in 1974 using a tubular retractor for doing the lumbar disc herniations. And as we know, Cambin and Sampson introduced image intensifier in percutaneous discectomy to help needle placement. In 1990, Cambin also described anatomic safe zone for the arthroscopic microdiscectomy using the Cambin's triangle. And 1992, Lee et al. Developed percutaneous endoscopic laser discectomy. And also we know that the Matthews 1998 and also Ditsworth opened the endoscopic era via transforaminal approach. And we are in Indonesia, started these procedures since 2008. And the last 4 years, we aggressively use these procedures for almost all the compressions in spine surgery. And as we know that endoscopic procedure has been used widely in spine right now. So if you look at the studies that we try to look at the PubMed, so if you write success rate of endoscopic procedures, then the results since 1989 to 2020, the results only 186 that talking about the success rate of the endoscopic spine procedures. And if you look at, if you write success rate of percutaneous endoscopic lumbar discectomy, and the results only 31. So that's mean not all studies talking about the success rate of the endoscopic spine procedures, but I'm sure it is probably it is not all the picture of the endoscopic itself. I'm sure a lot of people already right, but it is just PubMed probably. And if you look at the more studies about that, so the success rate around 90 to 89%. This is the interlaminar procedures that we have done. If you look at the usually talking about the interlaminar procedures, usually we use for the L5S1, and very rare doing the interlaminar procedures for lumbar disc herniation for the L34 or L45. It depends on the interlaminar space. If it is quite big, then we can use the interlaminar procedures for doing that, or we use the bigger diameter of the scope. And this is the result. So I'm sure everybody knows about the interlaminar. Then actually, I'm sure all agree with us that the one of the procedure for the L5S1 is the interlaminar procedures. This is after procedures, and this is the PLD transforaminal. And if you look at the result is quite okay. So after these procedures. So actually, for the transforaminal, it depend on the foraminal itself. So if you have a big foraminal, it's very easy to use that. But if it is 4L5 as well, it depend on the iliac crest that you are dealing with. Sometimes very hard. If the iliac is too high, then you have to do the foraminoplasty first before entering this. All right. Another than another case, this if you look at the lumbar dysgenesis and 4-5, that we do the transforaminal, then this is the after surgery. And we have also doing PSLD for central stenosis, right? This is before and this is after. Basically, the PSLD is the endoscopic interlaminar. Is not really is not really a new one actually. It is like a interlaminar procedure, but we're using the bigger diameter of scope. And we also using a PSLD for the foraminal stenosis from the lateral. Then we just cut the SAP and we enter the foraminal. And this is also we do also unilateral biportal decompression that will mention explained by Dr. Asrafi Rizki Gatam later on. Then basically this type of UB is very useful for the fusions. It's not just decompression, but you can use for the fusion if you want to fuse the lumbar spine. And this is the result after surgery. And if you are talking about degenerative scoliosis and stenosis like this, right? So is it equal to use the decompression using a endoscopic? So in our institution, we just try to do the decompressions by using endoscopic for this kind of patients, for these particular patients. But sometimes, you know, the result is not really satisfied because these patients has a degenerative scoliosis, has a foraminal stenosis like this, and also have a central stenosis. So sometimes you will have a bad results after surgery. Patients still have a pain because of so many stenosis that sometimes the neuropathy has already happened. So you cannot measure the results or the result or the outcome after surgery. So the question is it ideal for the endoscopic decompressions? And the question, is there any factor that influence the favorable outcome for or failure that influence in endoscopic spine procedures? So probably sex, smoking, BMI, alcohol, or level of pathology, type of procedures, surgeon experience, or other pathology or anatomical shape is influenced to have a failure or good outcome. So then we run a study about that. So we try to analyze our patients, and the inclusion criteria is a patient that requires subsequent surgery because of persistence or recurrent within 6 months after surgery, no pain interval from the first operation to the subsequent procedures, and radiological verification of remnant fragments. The exclusion criteria is subsequent surgery because of recurrent symptoms after more than 3 months, 6 months, or pain-free period following the operations, and recurrent herniation after previous open lumbar surgery. So our results since 2010, 2020, we have almost 2,000 patients. The transfemoral procedures, 500 cases, around 39%. The interlaminar procedures around 800 or 775 patients, around 61%. But my study only since 2010 to 2019, so around 1,133 patients. We evaluate 1,133 patients. So among the 1,100 patients, 400 around 400 is transforaminal approach, and 630 is interlaminar approach. And our failure rate is around 120 cases, around 11% of or 10 to 11% of my patients. So if you look at the factors that affected the surgical failure, is age. Is more than 60 years of age is more failure than less than. So, but smoking history is not really significant in our studies. BMI, overweight, is significant, and diabetes is significant also if you look at the our data. So level of pathology. L4-5 is more difficult than the other side. So it is probably because of the L4-5, whether we want to enter the L4-aminal or we want to enter from the interlaminar space, because sometimes if you decide to do from the interlaminar space, then you have a small space, then it's very hard to remove the disc. So the anatomical shape also have a role, but in our studies, it's not really significant. Type of herniations contain location of herniation disc also has a role that probably influence to the better or bad outcome. So the onset of symptoms, a lot of people said that the early onset is good and late onset is bad. Yeah, more than 6 months, usually there's some studies said that more than 6 months, the lumbar disc herniation, so our disc herniation have a bad outcome rather than the early onsets. The clinical symptom is not really difficult, only significance. But if you look at the surgeon experience in our studies, less than 50 times and more than 50 times, it's not really significant. But a lot of people said that the surgeon experience is very important to decide whether your procedure will good or bad. Type of procedures, transforaminal, PLD or interlaminar or PSLD also not significant. So the factors that we can get from our studies, diabetes, obese patients older than 60 years of age tend to have a disc and bone degeneration, so it's more difficult to remove the fragment. And the other hand, the older people tends to difficult to express pain, whether so sometimes when the surgeon asks in the intraoperatively. The level pathology L4-5 often experience pathology, whereas due to the narrow interlaminar space, and it is difficult for surgeons for doing the surgery. So discussions, if you look at the some studies, these are the studies running by the Sang Ho Lee that conclude that the PPD, significant improvement of pain in these patients, the result of their analysis is pain durations less than 6 months, positive SLR, and subarticular disc herniation, and the protruded as a when predicting factor associated with the successful response. So if you look, these studies said that if you have a early onset is better than the late onsets. Other studies talking about the surgical failure, around 10%, and the older patients also age more than 60s has a bad result, and diabetes also have a bad result rather than the normal patients, particularly then. And also, if you look at the other studies said that the younger patients younger than 40 years has a good result. And this is one of studies that we want to emphasize, that the large herniations, obesity, instability, smoking, and advanced facet degeneration decrease ability to cope with the surgery, then has a bad result rather than the usual these herniations. And this is the other studies said that satisfactory clinical outcomes, it requires a highly experienced endoscopic surgeon, and the learning curve is relatively steep, and the clinical outcomes could be affected by the surgeon's techniques. So if you look at our studies, said it's not really significance between less than 50s or more than 50s. Probably it is the cutoff is too high. And as a conclusion, the successful outcome depend on several factors: the age, smoking, BMI, comorbid diabetes, level of fatality tend to less favor. And the other consideration that we have to keep in our mind, that probably surgeon experience and type of herniated probably has a role to have a bad or good outcome. Thank you very much for your kind attentions, Professor Malcolm. And
that is a wonderful lecture, Dr. Lufti. You compared many of the issues that affect endoscopic spine surgery and its outcome. So that was a very wonderful and informative talk. There was one slide of yours which compared the outcomes between PELD and Interlaminar, and which there was really not much of a difference. So that was a very interesting part of your talk.